From the classroom to the emergency room, OR and beyond, you're joining Trauma ICU Rounds with your host, Dr. Dennis Kim.
Welcome back to Trauma ICU Rounds. I'm your host, Dennis Kim, and I've got to say, I'm really excited for today's rounds. Joining us on the podcast today are several colleagues and professors from both Texas as well as California who will be discussing the pros and cons of performing a subtotal cholecystectomy in patients with a difficult gallbladder. Joining us from Lubbock, Texas is Dr. Sharmila Dissanaike. She's a professor and the Peter C. Cannizzaro Chair of the Department of Surgery at Texas Tech University Health Sciences Center. Out of Dallas is my buddy, Dr. Michael Truitt. He is the Committee on Trauma Chair for North Texas. He's also the Trauma Medical Director and Program Director for the General Surgery Residency at the Methodist Dallas Medical Center. Out of California, we have two of my partners, one Dr. Angela Neville. She's a professor of clinical surgery and the program director for the General Surgery Residency Program here at Harbor UCLA. And we also have Dr. Jessica Keeley, who is an assistant professor of surgery and the newest addition to our Trauma ACS Surgical Critical Care faculty here at Harbor. We're also very fortunate to have Dr. Christian D. Virgilio join us. He's a professor of clinical surgery, co-chair of the College of Applied Anatomy, and chair of the Department of Surgery at Harbor UCLA, and he will be co-moderating the discussion with me. So welcome, everybody. So a couple of weeks ago, the topic of subtotal cholecystectomy came across my Twitter feed, and I found myself in the unpopular position of advocating for converting to an open cholecystectomy among patients with a difficult gallbladder. Dr. Dissanaike, you've written quite a bit about the technique for performing a subtotal cholecystectomy, and I know there are currently a couple of ongoing multi-institutional trials examining both the use of subtotal cholecystectomy as well as the optimal technique for performing this procedure. To get things started off, maybe you could explain to us, what do we mean when we say that someone has a difficult gallbladder? And when do you think we should consider converting to a more damage control approach to this particular clinical situation?
Thank you, Dennis. I appreciate being here, and it's a great topic. So thank you very much for hosting this podcast and having me on it. So I think that, just like every family is dysfunctional, but we're all dysfunctional in our own way, every difficult gallbladder is dysfunctional in its own way. And I think that is a fundamental point to understand. So, for example, if the gallbladder is difficult because it has a possibility of having cancer in it and everything's stuck to the liver, or if it's stuck intensely to the duodenum and the colon, or if bleeding is happening that's difficult to control, to me, that variation of difficult gallbladder is actually a fabulous indication to convert to open. And that is what I do for those indications. So I want to start out by saying, and forgive me for this, but it is so unusual for me to ever be on the side of an argument where I'm advocating for laparoscopy instead of open. I am so lucky that I was old enough and I chose the right field, trauma ACS, that I get to do open cases all the time. And I strongly push my residents to use the robot. I think it's great. But my goal is to finish my career not ever having to touch the darn thing myself, because I love open surgery. So let me preface it with that. Love open surgery. My problem is this. When the difficult gallbladder is for inflammation, which is 90+% of the time, right? It's chronic on acute on chronic cholecystitis, and it's inflamed in the triangle of Callot. I don't see that exposing that to the room air makes it any less inflamed. It doesn't make it easier. And so for me, that variation of difficult gallbladder from severe inflammation does not benefit from open, and it does benefit from subtotal. And not only does it not benefit, it actually can worsen from open, because most open surgeons use a dome down approach. And we can maybe go into this in a little bit, but that actually can result in a worse injury.
Good point. Dr. Truitt, when this all happened a couple weeks ago, I know that you were on my side. You thought that we should always open for these difficult gallbladders. So for our audience, why don't you give us your take on the subject?
No, I'm on the side of subtotal. We got involved in this some years ago and did the first stages video on the topic. And honestly, that was really, I think, where I started thinking about this in more depth. I think up to that point, I was doing kind of what you and what we had described, which was converting to open. And to Dr. Dissanaike's point, I found that when I opened, it was still hard. It was still bloody. Lots of my patients were obese, and so it was a deep hole. And although I trusted my open skills, I didn't find that it actually made the operation easier. And then I had the issues with subjecting the patient to the kind of short and long-term wound complications.
Dr. Virgilio, any thoughts or questions for our panelists?
Well, I thought maybe our experts could give us some overview of what are the actual options when you encounter a very inflamed gallbladder. In other words, both open and laparoscopic options of what to do, and the different definitions of subtotal, because I think they can sometimes be confusing.
Absolutely. Dr. Virgilio is right. If you don't mind, Dennis, I'll take that one since I mentioned one already. I said dome down.
Absolutely. Go for it.
Okay, so the classic open cholecystectomy is dome down, is how it was taught, a long time ago, which actually works great for a non-inflamed gallbladder, by the way. And it's where you start dissecting at the top and make your plane between the liver and the gallbladder first, till you have your gallbladder just dangling off its arterial supply in the duct, and then you ligate that in some form or fashion. The reason I don't advocate for that approach, I actually will not allow a resident to even attempt that approach in a severely inflamed gallbladder, is because the inflammation can get so thick that the classic error the surgeon makes is that they think it's still gallbladder wall with the inflammation, so they go deeper and deeper into the liver, and they go off plane, so they're actually going at a tangential angle toward the biliary structures. And what they do is they usually hit the common bile duct. Really, they actually hit the hepatic ducts just above that confluence into the bile duct, and they usually get the right hepatic artery as well for good measure. So it's all three structures transected, which is a hideous injury to fix. It is a lethal injury. I've seen cases, not at my own institution, but where I've been called to review, where people have died from that injury. And I also know of at least 2 cases where patients had to proceed to liver transplant. So it is about as catastrophic an injury as you can do, and that almost exclusively occurs with that dome down technique. So that is the reason I'm sort of very much not in favor of that traditional approach in inflamed, severely distorted gallbladders. The 2 approaches Dr. Virgilio mentioned for subtotal, the accepted one, Strasberg wrote a paper in JACS a few years ago that delineated this. And I think that was an important step to help make sure we're talking about the same thing. Reconstituting is where you close the infundibulum and remove everything distal to that. And so essentially, you're not taking the cystic duct, you're taking it at the gallbladder. You can either do it stapled, you could resect and then sew, although almost everyone uses staples doing this. And the common criticism of that is you're just creating a smaller gallbladder, which interestingly, although that makes perfect sense, the data, and maybe we can go into this in a little bit, doesn't really bear that out. And I never use that technique because it just made no sense to me, but I've actually started occasionally using it now because the data really supports that it does quite well. The method that I wrote, a kind of step-by-step guide on, and that I advocate very strongly and teach all the residents, is subtotal fenestrating. Both of these, I recommend staying laparoscopic. In the early years, people used to convert to open, but I think that's totally unnecessary. But essentially, I use an energy device, come across the infundibulum, and then you take all the anterior lateral walls of the gallbladder, leaving just less than a centimeter, ideally, of rim above the cystic duct. So that's a fenestrating. And so those would be the major types that we're talking about when we talk about these damage control options.
Now, it's interesting because you mentioned with the inflammation, you don't recommend the top-down approach, and that's actually my go-to approach. I almost always go top-down. We're always sure to have, a baby metal Yonkauer available that we can use to help bluntly develop that plane between the inflamed gallbladder and the liver, and, that index finger also works quite well for that as well, especially when it's inflamed. It's almost like the gallbladder just peels off the liver and keeps you in the right plane.
Or the liver capsule tears and you get a complete bloody mess. That happens too when you bluntly dissect if you're not very good at it.
Agreed. It's not uncommon for there to be some oozing from the liver. And for me, once I have enough of the gallbladder mobilized, I typically will place some Surgifoam and noon it with a lap in that area, and then place a Sweetheart retractor to compress it and retract the liver. And then by the time we're done with the chole, hemostasis is almost inevitably perfect. Dr. Neville, we don't do a lot of subtotals, so maybe share with us what you would consider to be the indications for conversion to an open cholecystectomy.
I think that the times that are necessary to convert to an open surgery, it's usually when you're working laparoscopically in I would say more of a chronically inflamed situation, but in acute chole, the fat is very friable and it's very easy to dissect through. I'd say a more acute or chronic, acute on chronic or subacute or really a chronic cholecystectomy is where I feel like difficulty in doing the dissection laparoscopically ensues. And I think the other situation, which is kind of a corollary to this, is like a type 2 Moritzi syndrome, because that's about the only time when you're not going to be able to really get the gallbladder off of the common hepatic duct, and that is and that is going to need to be open no matter what. Moritzi syndrome is usually when there's a stone that is in the infundibulum that's compressing usually the common hepatic duct and leading to intraductal dilatation. And the type 1 is just when there's an extrinsic compression of the bile duct, and type 2 is when you develop a cholecystobiliary fistula. And those are the ones where you're going to absolutely have to deal with that open. So the question then is, when you have a chronic problem or chronic dissection, can you decide whether or not you actually are dealing with a fistula or not? So those are the situations where I feel like it's really imperative to open, so you can define and identify your anatomy and make sure you're dissecting safely. And in the event that you end up with a fistula, you're going to have to repair it. And I would not feel comfortable doing that laparoscopically. And I don't think many of us would.
So can you clarify, when you say fistula, you mean what type of fistula? I missed it. I apologize.
I mean, when the gallbladder is actually, the stone has eroded through the gallbladder wall into the common duct or common hepatic duct usually. And literally, so you think you have an actual injury, but in fact, the stone had really was an erosive process that had caused a fistula to form. And I think that's where I think sometimes that's where people think they've actually made ductal injuries, but it's really the nature of the chronic disease that's caused the hole in the common hepatic duct.
So I had a question for Dr. Keeley. Taking a step back, if you have you anticipate that the cholecystectomy is going to be difficult, and let's say it's an elderly patient with 2 or 3 day history of symptoms, a very thick-walled gallbladder, very high white count, and it's midnight. Do you start that difficult gallbladder at midnight, or do you wait till the morning?
I try to wait until the morning unless someone is really quite septic or has an obvious need for immediate source control. I try to do that as a first case, or at least during the day. Typically, I stop doing gallbladders before midnight, typically by 9 or 10 p.m. 1, because we're a busy trauma center and I'm often pulled in several directions. And 2, there's some good data to suggest that doing a difficult gallbladder during the day will known complications like bile duct injuries.
What about the rest of our experts here? What are your thoughts on starting the difficult gallbladder at beyond midnight?
I'll let Mike go first. And then, yes, I have some strong thoughts on that. You'll be shocked to hear.
I think we've all kind of migrated over the years to these cases. Really should be in the light of day, where there's another pair of eyes, another pair of hands. Unless, as was mentioned, there's a compelling reason, physiologic reason to do it in the middle of the night. There's really no reason to take these cases on in the middle of the night for all of the reasons mentioned.
Agreed. Why would you do this? And so, another pet peeve of mine is that we don't get reimbursed very well for these incredibly difficult cases, right? You don't make a lot of money doing these very hard cases. They're high risk. Why would we add to the risk by doing it at midnight? Because heaven forbid something goes wrong. Any lawyer with half their salt could probably make a case that contributed. It's hard to say it didn't, right? So I really think buyer beware. I think we have to look after ourselves as well as surgeons. We have to make sure we don't put ourselves in situations where it's hard to defend our actions. And much as I don't like practicing defensive medicine, I think this is one case where we kind of need to and give ourselves the best chance of success.
Well, it's interesting, Dr. Dissanaike, that you bring that up, because I know at your shop, you and your ACS surgery group are on a shift schedule, whereas we continue to do 24s. I'd imagine that the evening or nighttime surgeon is still kind of fresh, whether it's midnight or 1 a.m.
So they're doing operations. We'll do gallbladders running later into the night as a result. So you're absolutely right, Dennis, because we have a fresh surgeon, fresh crew. We do run it later. But remember, after midnight or so, you're still down on anesthesiologists. That is sometimes our peak stabbing and gunshot time. And we don't want the risk that while you're doing that difficult dissection, a gunshot wound comes in that you have to deal with. And, how could we justify that to the patient? So what we'll do at any hour, our appendicitis, we do that as outpatients. Bowel obstructions, of course, incarcerated hernias, but gallbladders will stop around 9, 10-ish, finish up around then, and whatever's left over, bump that to the next day still.
I think the other consideration there is it's not just the resources at night in terms of what you're covering, but it's again, kind of the thing we mentioned previously, that other set of eyes. I've been, out of training since 2007, and I still ask on occasion, and I'm sure each of you do as well, if I see something doesn't look quite right. I love having the opportunity to ask one of my HPB colleagues or the transplant guys to come in and just, hey, what do you think? What do you see? I don't even tell them what I see. I say, what do you see? And we see if it's the same thing. And then that gives me that kind of even increased level of confidence of knowing that we're doing the right thing. And then beyond that, if there is a complication, you may be fresh because you're doing a 12-hour shift. But that doesn't mean that your HPB colleague, if he or she were required, would be available at 2:00 in the morning.
Oh, very good point. Dr. Neville, you had a comment.
I think that certainly judgment is involved. And, if we consider what are the risk factors for either a difficult gallbladder or conversion to open, a male, an obese patient, an elderly patient, a patient with multiple comorbidities, certainly those are patients that if can wait, should wait. If you have a 23-year-old who's had 2 days of pain with a small gallstone at the neck, I don't know that that's not any more or less challenging than an API. So I just put that out there as just, again, using clinical judgment in deciding these things, I think is useful.
Our team just doesn't get any easy cases, though. That's what it is. Our community colleagues get those. We literally, it's kind of funny. Our team is called U2, and we call it the U2 gallbladder. And the residents will say, boy, these are so different to what everyone else is doing. We're like, yeah, they're all terrible. We have a high uninsurance rate, right? And underinsurance in Texas. They're all 1 year into it before we see them. I hate to say it, but it's a reality.
Yeah, no, we have a pretty similar patient population here, I think, in South Los Angeles. Several years back, we actually published a paper in the American Journal of Surgery on this exact topic, and this was presented at the Southwestern Surgical Congress. We actually found that for those gallbladders that were performed between the hours of 7 p.m. and 7 a.m., there was in fact a significant increase in the number of conversions without a decrease in length of stay or an increase in complications. And I suspect, although I can't say for sure, that, if you're getting a gunshot wound or multiple stab wound victim at 1 or 2 in the morning, now you're kind of dividing up the team, you're more likely to abandon the chopsticks and the camera open in an effort to get that surgery done. Now, Mike, earlier we were talking about Morizzi's syndrome and the potential need to convert. What are your thoughts on that? Is that something we should be doing routinely, or is this in fact the ideal case to do a subtotal cholecystectomy?
Yeah, I think it depends on the surgeon. And that's maybe kind of a cop-out answer, but it really depends on your skill set, on your comfort level. I first of all, just would love to say that I think having the skill set of being able to do an open cholecystectomy is critical. And I want our residents to have that too. But then the question is, do they have the skill set? And that's our job to teach them. And then the second part is, when do they employ it? So I think Morizzi's is actually a very reasonable disease process for that to be employed pretty regularly. There are laparoscopic surgeons that I think could handle that case minimally in an MIS way and do it well and have good outcomes. I just think you have to know what your skill set is, what your institutional resources are. And again, our job is to make sure they can do it open, lap, and robotic and do it safely. And then figure out when those techniques need to be employed in which patient population. And that's the hard part.
Yeah. So on that topic of Maurizi syndrome, you hear stories of surgeons sort of being surprised in the OR on occasion at discovering Maurizi syndrome. And so what clues preoperatively, say on duplex scan or on labs, might one of our experts share that would help you sort of recognize the possibility of Maurizi's ahead of time so you're prepared heading to the OR?
Yeah, I was going to say, I think usually if you are encountering a patient where you're concerned that there may be an element of choledochal based on the LFTs or mild intrahepatic ductal dilatation or dilated common hepatic duct, you're not seeing a lot of small stones, you may be just seeing a large stone. I think that's the indication for employing a CAT scan. A CT scan can help delineate the anatomy, or potentially an MRCP, depending on your institution. Usually, if we have a preoperative concern about Maurizi's based on the imaging, so start with our ultrasound, then it's not quite clear, we get a CT scan. If it's a clear-cut Maurizi's, we probably, and the patient has significant LFT elevations, we'll probably go straight to ERCP, because it really helps to have that defined, and also an intrahepatic ductal stent, a CVD stent in place. And then if there's controversy in MRCPA. So I think really having your anatomy of the biliary tree identified preoperatively, and if it's something that looks like there is concern that there's an erosion in the form of, like we were saying, fistula, to make that decision. If it's really concerning, we'll ask our HPB colleagues. If not, we'll usually take on those cases ourselves, but with a much higher indication, definitely during the light of day, definitely first case, with backup from our HPB colleagues if necessary, knowing that we could have issues later on. So I think just a very good preoperative workup is important as you kind of prepare for this type of surgery.
Yeah, so I wanted to shift gears for a second on the topic of resident training and common bile duct injury, because as everyone here knows, in the early era of lap chole, there was a real concern about the common bile duct injury rate relative to the open chole. And we always say that the open chole rate of injury is way less than lap. But I guess the question today is, can we still say that? Can we still say, given the training of current residents, that the open chole is actually better in terms of duct injury rate? I wanted to hear comments from our experts on that.
So I would say absolutely not. And the only time in the history of that we know that the open cholecystectomy had a lower bile duct rate was when they were all being done open, right? So when all the easy gallbladders were being done open as well, absolutely. If you look at any modern series that we are now doing exclusively conversions, right? No one starts out open anymore. It's all conversions. The rate is higher in almost every series. And so actually your neighbors, Dr. Dimitriadis and colleagues published their data about 2014. And they had a significant amount of conversions as well as some subtotals. And they had 5 bile duct injuries only in the open group, none in the subtotals. That's consistent across really global meta-analyses and things that have been done. We have our data submitted for publication this year. In the last 5 years, we did. And so it's interesting to me, despite me pushing so hard for fenestrated, lap choles and definitely subtotals, we had of the difficult ones. And remember, we do a ton of gallbladders that are really bad. So this is actually quite a small number in 5 years. This is one institution's data. We had 55 laparoscopic subtotals, and we had 85 conversions to open. So it was still in favor of open. And the only bile duct injuries, there were 2, were in the conversions to open. We had 0 in the subtotals. We had bile leaks, of course, from cystic duct. You expect that when you're doing a lot of fenestrated. I don't consider that a complication that's expected, and we can argue about that. But actual common bile duct injury or major biliary injury, the only cases were in open. And this is in series after series, if you look at it. So I think if you're going to look at the data at all, you have to say in modern times, the risk of common bile duct injury is higher. And it may be that if you look at your own series and you're doing enough of them that you're really good at it and you have a low rate, that's acceptable. But when the rate in the subtotals is close to 0, it has to be really low for that to be acceptable. And really, a lot of us have series with a common bile duct injury rate of 0 in places doing a lot of subtotals.
I guess the question that I have for that data set then is if, why were some people because this goes back to, when people die of a bad injury and you say it's the procedure, it's not the injury. I guess the question is, why did you convert to open in some people and do the fenestrated in other people?
It's based on the surgeon, right? So a lot of surgeons still were trained to do open as conversion as default. And so it took a while for us to evolve. So if you look at the timing also, you'll see that each year it shifted a little bit more towards subtotal. So whenever you do retrospective, you have to understand people started with open being the basis, right? That's what most people my age and older were taught. So we're just watching that shift happen. I can tell you, if we look at last year's data, you will see much fewer open conversions and more subtotals as we evolve. And of course, you're going to have 1 or 2 strays, like I said, that we will do for cancer or bleeding problems. But it's an evolving trend.
Mike, you had some thoughts or comments?
No, I was just going to say, I think we're actually finally seeing this come full circle. The fly in the ointment when we first started with cholecystectomy was that the bile duct injury rate was high. And that was secondary to lack of experience and also to people trying to figure out what to do in this very circumstance that we're talking about today. When you can't get the critical view, when you can't dissect down low safely, we had lack of experience and a lack of tools in our tool chest to employ until the bile duct injury rate was high. I actually think it's going to be very interesting to look up to 5 years from now, and we're going to say, okay, the lap bile duct injury rate is actually going to be less than it ever was. So it was high initially for the reasons we just talked about. It's coming down now because people are potentially employing this technique that keeps you away from that significant inflammation and up high and kind of live to fight another day. So this is actually, I think, the natural history of this whole thing finally coming to where we've evolved. We've figured out some tools to employ that will get us not only as good as we were before in the open era as it relates to BDI, but even better. But then we also have all of the benefits of MIS techniques as it relates to wound complications and hernias and that sort of thing.
There was a study just published last year out of LAC USC, published in Surgery, I believe, that looked at the NIST database to examine trends in the utilization of subtotal cholecystectomy as well as laparoscopic versus open surgery. And what they found was that indeed the incidence of both laparoscopic and open subtotal choles have increased over the last decade or so. But the question I always find myself asking when it comes to the meta-analyses and single institutional studies looking at common bile duct injuries is, when it comes to bile duct injuries, is it that patients were converted and then they got their BDI, which I think is less likely, or is it that there was an injury and therefore the surgeon decided to open in order to further investigate?
So, Dennis, I think you're right. You're not going to see that in a meta-analysis, right? You're not going to get that granularity. But that's why I mentioned our own series, because you can, if you're looking at source data and op notes, it says what point they recognized it. And I will tell you, if you look at those single center series, there's a few that have been published, including our own now. It does seem to be that it happens after the conversion. I did want to make one point, though. To me, an open subtotal is giving the patient the worst of all worlds, but I think it's an inevitable part of the learning process, and that's how I look at it. And so in our series, we had 10 open fenestrated lap choles during this 5-year period because it was people getting used to this concept, right? They opened because that's what they're used to doing. And then it's still hard, just like they said, it still looks terrible. They still can't understand what the anatomy is. So then they made it a subtotal. Those happened early in our series as we evolved. And so I think that, to me, I would look at open subtotal very much as a transition. It should not be the endpoint. To me, the endpoint is lap subtotal. And I agree completely with what Mike said a few moments ago. I do think the goal should be 0 common bile duct injuries for lap choles, honestly. And I think we'll get there by shifting more and more toward the subtotal approach.
I wanted to kind of pick the brains of the group here. We've noticed in the kind of last 12 months with COVID that there have been an increased number of gallbladders that were treated with a C-tube, either because they were COVID positive and there was some thought early on that maybe those patients shouldn't get operated on because of increased risk of thrombotic complications. And then also just sometimes people using C-tubes, I think, largely inappropriately. But we're seeing a large number of those patients now flow back into my office as an outpatient they've had a C-tube in for 3-6 weeks, sometimes 3-6 months. And I found those have been, and this goes back to what we were talking about earlier, the acute inflammation is usually friable and you can dissect it. But this chronic inflammation from a C-tube, these are some of the hardest gallbladders that we've ever had to do. Have other members of the panel had a higher incidence of kind of chronic cholecystitis with C-tubes? And if you had the same observations with how difficult those cases can be?
Yeah, I don't know that we've noticed an increased trend or an increase in the use of cholecystostomy tubes in the last year or so, but we certainly do see our fair share of patients who are managed initially with a C-tube. I do remember a time not that long ago at a particular institution that I was at where this was actually the front line or first line management therapy or strategy for patients presenting with acute cholecystitis combined with antibiotics. And Mike, I completely agree with your observation. These are among the toughest gallbladders to do as a result of the chronic inflammation, the adhesions. It's a never a nice procedure to do. And I agree that dissection is so much more difficult. So in general, my personal preference, and I think that of our group, is not to place a cholecystostomy tube, except in those cases where it might be indicated. So for a critically ill patient with an acalculous cholecystitis who's on multiple vasopressors in the throes of shock, in whom a cholecystostomy tube would be a very reasonable and safe management option.
So we haven't, only because we've managed to change that culture a lot. The Blessed Tokyo guidelines have something to answer for with that, because we did see this spate of PERT chole tubes, and I'm glad that's been sort of modified and refined now. One of my division chiefs had a great solution to this. If you were the surgeon consulted and you recommended a PERT chole tube, he made a rule that on that service, you had to take the gallbladder out if you're the one who makes that recommendation. No dumping it to anyone else.
I love that.
That works really well. So I would strongly recommend that whoever recommends the PERT chole tube has to be the one taking the gallbladder out eventually. It works nicely. And we have actually reduced our rate, thank God, because that was a pet peeve a few years ago. And with COVID, one thing we did, Dennis, seeing that this was long-term and not short-term, we never stopped doing acute cholecystitis. We also never stopped doing cancers because we saw we were going to pay the price later at this institution. So I am very fortunate that here in Lubbock, West Texas, we were able to care for these patients throughout. So we didn't see the problems a lot of others around the country did with the delayed care.
Yeah, so it seems like when deciding between conversion to open versus creating a fenestrating or reconstituting subtotal, you're weighing the risks of fistula with a fenestrating versus recurrent stones with a reconstituting versus the risk of CBD injury and morbidity of an open procedure. Can anyone sort of comment on what are the relative risks of these adverse events with these different approaches?
So the fenestrating has about an 18% bile leak rate. I mean, I would say it's 100. I think it's 100% immediately because you're leaving the cystic duct open. Most of us don't even try closing it anymore. So I always leave drains. But sort of delayed beyond a week or so, it's about 18%. You can drop that number with ERCP. So one thing, Christian, is that definitely your reintervention rate is higher with the subtotal techniques because they tend to get ERCP. How bad is that? I don't think it's that bad. We do ERCPs a lot anyway, so I don't consider that a complication, but there is that reintervention rate. With the reconstituting, interestingly, so this is where my practice has changed. It makes sense to me they would have a higher reoperation rate, right? Because you're leaving a bit of gallbladder closed. Oddly enough, no. The reoperation rate is below 5% in almost all series. And in the series where it's a little bit higher, which have bigger meta-analyses, larger reviews, it's actually higher for subtotal fenestrating than it is for reconstituting. I can't quite explain that. There's a nice Dutch study that looked at all their centers, put them together, and it was actually 9% for fenestrating, 4% for reconstituting. So reoperation seems to be actually a little bit high, but it's still in most series. That's actually the highest number I've seen. In most series, it's below 5%. For those two techniques. So those are the most common complications by far of the subtotal techniques.
Yeah, as I say, I would just chime in and say that I think one of the things that we suffer from right now in trying to figure out which of these techniques is best is that they haven't been standardized. Yes, there's been some nomenclature assigned to them recently, but in terms of looking at the outcomes, again, there's so many little things that matter. How big of a gallbladder stump did you leave? Was it a centimeter or was it 10 centimeters? People talk about suturing the cystic duct. That to me seems absurd. The whole reason that I am trying to do this partial or subtotal cholecystectomy is to stay away from the high rent real estate areas. And now I'm going to try to suture inside of a hole in a thing that's really inflamed. And so I think that is something that I try to stay away from, is trying to suture the cystic duct. I also don't like the idea of reconstituting, not only because of the risk of recurrent cholecystitis, but also because lots of times it's done in a stapled fashion. And I will say it's been 7 years or so now, but at the beginning of the subtotal chole kind of era, we had a couple of bile duct injuries that were lap subtotals, where someone took a stapler across what they thought was the gallbladder, but instead they did a transection and resection of the bile duct. And so again, nothing is 100% safe, particularly early on. But you won't, the stapler, it's such a significant amount of tissue that is resected that I really don't like that technique. I feel very strongly about fenestrating, leave the cystic duct alone, leave a drain. Dr. Dissanaike talked about the cystic duct leak rate there. If you take that out to 14 days with no reintervention, the need for ERCP is about 2%. So if you're willing to wait, this will close up on its own, assuming there's not a distal obstruction. And so I think, again, we have to define these terms. How long are we going to wait? How much gallbladder are we going to leave behind? Are we suturing close the cystic duct? Yes or no? And until we standardize all of those things, it's going to be very hard to come up with what we think the kind of ideal scenario is.
I think the concern that I have is that we have seen people come back with their subtotal cholecystectomies. And let me assure you, taking them out with their remnant gall.
You mean with recurrent cholecystitis, you mean?
Choledoco.
Remnant gallbladder, recurrent cholecystitis. I feel like we've probably seen that more frequently than we've seen PERT chole tubes over the last couple of years.
Those patients, to do those cases, are much harder. And I feel like we're trading one disease process for a yet kind of undefined or emerging. We're going to find a new disease process. The recurrent cholecystitis and a subtotal, a much harder operation because it's already been dissected. And then you're talking about, yes, a much more scarred triangle. The other thing is, it took the people, 40 years to form their gallstones. So now we're trading we'll give them a few years and we have a few years of data, but when they're going to get the recurrent cholecystitis now when they're 80 years old, and now we're going to be dealing with a huge other process. So I still feel like if we can get the gallbladder out, we should get the gallbladder out, because I don't know that these new, I don't know, maybe if we define them better, but it just seems like we don't really know what's coming, I think.
Yeah. And to follow up on that, Dr. Neville, and what Dr. Truitt was saying earlier regarding the need to standardize definitions or terms, I still don't understand what is meant by a difficult gallbladder. And my concern is that there may be a lot of junior attendings and young folks out there, or even more experienced mid-career folks who look in, they see an inflamed gallbladder with adhesions and say, ooh, that's a difficult gallbladder. I better do a subtotal cholecystectomy. Whereas in fact, with a little patience, maybe a second opinion from a senior colleague or hepatobiliary partner, or just anyone with more experience, you could safely dissect out the gallbladder, define the anatomy, and do a total cholecystectomy.
The other question I have is when, and I think, and Dr. Keeley and I were talking about this earlier today, and is, what are the medical legal kind of what do you tell people? Oh, do you tell people you took out part of their gallbladder? Do you not? Because we, there's a lot of medical illiteracy, at least in our population. And so, they think they got their gallbladder out, but they didn't really get it all out. And so they go to someone and they say, I got my gallbladder out. And then you get a CT scan, which has happened to us multiple times. And oh gosh, look at that. There's still a gallbladder in with some clips or a staple.
Two things. So a lot of points there. If you do a subtotal and you get a CT scan anytime in the next 6 months, it'll look like the gallbladder is back. I'm sure Mike has had this experience before, because the fluid seroma collection forms in exactly the shape of the gallbladder fossa. So firstly, everyone does need to know that if you scan these patients, you will look like there's a gallbladder there. Now that goes away with time, but the first 6 months, it looks like you did nothing. So I warned the patient of that, actually. And of course, you always have to talk to your patients. So subtotal, I always explain that to them. I explain it's a drain. And I explain that this was done to reduce the much worse complication of a common bile duct injury, because you've already talked to the patient about a common bile duct injury. Actually, at this point, if I have a high-risk patient for this, obese, male, 2 years of symptoms, this is now the worst one, I will give them the option of a subtotal and talk to them about it before the operation. So absolutely, you have to talk to your patients. I think that goes without saying. However, I think it's important to know the medical legal things. Lawyers read the medical literature probably better than some of the physicians, because I'm contacted when I first wrote that paper and started talking about this now about 5-6 years ago. You would have no idea how many lawyers across the country contacted me to serve as expert witness on common bile duct injuries. So it tells me two things. Common bile duct injuries are happening a lot still from lap choles. They are definitely not gone away. We're still happening a lot. Just so you know, I always said that conversion to open, which is what almost all of these surgeons had done, was still standard. And I wasn't going to say that these surgeons had done anything wrong. And so usually they didn't want me much after that. But the truth is they are quite aware that there is an option with documented lower common bile duct injury rates out there. And so I would say if you're going to be medical legal, it's going to be a little harder and harder, honestly, to justify open. And I don't mean that to be difficult. I think that's just the way this is going to go.
I think the point that Dr. Kim makes about potential overutilization, I feel like a politician. I'm kind of riding the fence on some of these things, but I think just like any damage control technique, if we overly utilize it when it's unnecessary, then we're taking on additional risk without benefit to the patient. So I do think that it's really important. And again, it goes back to definitions of, okay, what is a difficult gallbladder? How long should I be attempting to get a critical view? Because sometimes what happens is you persist just long enough and now you're in trouble, right? You're like, oh, I think I can get it. So you don't want to bail out too early and have unnecessary subtotal or near total cholecystectomies. I actually really like the endocrine nomenclature for this. Instead of subtotal, I like the idea of near total. To kind of indicate what you would do for a thyroid, something similar in the gallbladder. So I think that's another way we could add to the definitions, how much gallbladder we're leaving behind. But I do think it's important that there probably are some people that are overutilizing this technique. And then you're going to see it and with some of the ways that you guys have seen in California where they bounce back more often than they should. So very difficult.
Like the open abdomen.
Yeah.
Right, just like the open abdomen.
Exactly.
It was great. We discovered it. Then we definitely overused it for a while, and now we're dialing it back. Yep. I think you almost have to go through that learning curve for almost everything. I also just say on the concept of retained and recurrent, remember, there is a rate of recurrent cholecystitis with long cystic duct syndrome, even with completion cholecystectomy. So our HPB surgeon had to do one this year for a completion cholecystectomy done 8 years ago. And the patient was all mad and there were medical legal ramifications potentially. But I mean, it was clearly a remnant gallbladder, but from an enlarged cyst. So, there's no good deed goes unpunished. I mean, I think we can never get that rate to zero. But is it worth avoiding a bile duct injury? I think that's what we need to discuss as a community as well.
To just follow up on a few technical points regarding subtotal cholecystectomy, because we really don't do those here, and so much for the saying that everything's bigger in Texas. But we talked about the recurrence rate of 4 to 9 or 10%. Now, there are other complications. You mentioned an ongoing bile leak for which patients may require prolonged drainage plus or minus an ERCP. But for those patients with, let's say, tiny stones, maybe some technical tips that you could share with the audience in order to avoid spilled stones, which we know are associated with a significant number of potentially short and long-term complications.
Yeah, I really like I'm a 5mm guy generally for gallbladders, except obviously for the extraction point. But if you use that 10mm sucker, and when you open the gallbladder kind of up high anteriorly, if you take the 10mm suction and go in there for small stones, you can actually extract, it's very satisfying, hundreds of stones in a matter of seconds through that sucker. So I really like that. That doesn't work great for bigger stones because it'll clog both the suction and the tubing. But for the little ones, you can you can really remedy that rather quickly with the 10 millimeter sucker.
My favorite case is when you're doing a subtotal and it's emergency, and so you have this one huge impacted stone. That is very satisfying and easy to do. But you're right, the millions of tiny stones is so annoying. So what I do now is I sometimes do expand, just like Mike, to that larger port in the epigastrium at 10 millimeter. But otherwise, just to make this easier, but I'll place the bag under the gallbladder. I open always anterior and high, and then basically empty all the stones straight into the bag. Get rid of that one. And then once you've done taking the walls of gallbladder off, you can pile them into a little corner and use another bag to take them out at the end. That saves you time, because you're absolutely right. Retained stones are a problem. They cause infection. We need to avoid it. It is really disheartening when you see those tons of millions of stones and then they spill out and you have to go hunting for them. But I will talk to the residents saying, nope, we've got to go hunting for every single one. The other trick I like to use is at the end of the case, turn the patient into Trendelenburg, right side down, wash aggressively, and then go over the liver and suck to make sure that if you dropped a few stones and didn't see them, they wash up into that above liver area where you can find them.
So getting back to residency experience, particularly when it comes to open choles, it really reminds me of the age of open appendectomies. And I will say that I still prefer to do open appies, particularly in thin males. And it's always done through a very small incision. But this seems to be a procedure that residents don't seem to know how to do anymore. So are they losing out? Are our patients losing out? Should we be converting more often to an open chole, or is subtotal really the way to go? Just recently, someone commented on Twitter, well, I've only ever done 3 open choles during my residency, so how on earth is that going to make anything better? Personally, whenever I open, the exposure is unparalleled. And we do perform these through smaller incisions in order to avoid those wound complications and hernias that people oftentimes cite. Now, Dr. Keeley, what are your thoughts on this, as you're a fairly recent grad from this program? And how many open choles did you do during residency? And how did you feel going out into practice and having to convert?
Sure. I did just under 40 open choles that I documented in my operative log. I actually felt relatively comfortable going out both into fellowship and then practice. The loss of that open experience is quite obvious, especially having been at multiple institutions over the last several years, just knowing how to get your chosen retractor in, how to lift the liver up out of the right upper quadrant, how to pack away the bowel and actually see the gallbladder.
So I did want to make one point, Dennis, onto your question about resident experience first, and I did want to take that one too. But how many splenorenal shunts have you done lately since TIPS was invented? Right? Not. So I would say that we don't have to train our residents to do every operation just because it's historic. So my argument would be that I don't think we need to do open appies, because if they have to convert, then probably it's a terrible case. They're making a midline incision and using basic principles to dissect your cecum and appendix, right? I mean, to me, that's a different operation from doing an open appy in a healthy young man like you described. So when they do need it, it's a different operation, kind of ditto for cholecystectomy. So for me, all it means is that, you know, Dr. Keeley's experience is very unusual. The average number is 10 and not 40, as you know. I don't know that we are never going to get it to where that's their default comfort zone. So given that it's not, that's one reason I advocate so heavily for the laparoscopic subtotal. It will not be their comfort zone unless you train in a place doing routine open cholecystectomies. And if it's not their comfort zone, when you do have to convert, then it's basic principles. We're in the abdomen open for a lot of other reasons. So that would just be the point I would say as to resident experience. Question on timing, I don't think we know the answer, but for me, it's, does it feel dangerous? Are we poking in things we can't really define? Are we not making progress? And is the inflammation that thick fibrous rind versus this, softer acute inflammation? Those 4 factors are what I use to make the decision. I do tend to make the decision earlier rather than later. But again, I advocate for this. It sounds like I do this all the time. Really, we didn't. Like I said, in 5 years, there were 55, and that's out of thousands and thousands of gallbladders. So we're not doing it just on every difficult gallbladder. But if you are going to do it, please do it before you make your injury.
Mike, thoughts?
Yeah, so I'm going to provide. So I moderated a session yesterday here at the APDS, and the title of the session was "The Robots Are Coming." And the last talk was given by Dan Vargo from the University of Utah. And I invited Dan to give that talk. And the title of his talk was "Robotics is the Beginning of the End of Laparoscopy." So I find this kind of funny. Like, we're bemoaning open surgery, and I'm kind of saying, hey, actually, we're going to have the same conversation 5 years from now around laparoscopy. They're not going to be able to do these cases laparoscopically. They're going to need a robot. And so it happens. This is part of the life cycle. I'm not saying that's good, or I'm not saying that's right, but I'm saying that this is what we've seen, and we've seen it from open to lap. I remember an attending in my residency back in Colorado who had to help a junior attending take out a spleen in open fashion because he had done lots of laparoscopic splenectomies, but he had never done an open splenectomy. And this is years ago, right? And so we've already seen this happen a couple of different life cycles. But the next one's not going to be the loss of open kind of technique or familiarity with it. It's going to be the loss of laparoscopic techniques and reliance upon the robot. So we have to figure out as PDs and as educators about how to keep all of these skills as relevant as we can, but also we have to recognize that we can't teach them everything. So I think Sharmila's point is really pretty good. Hey, if they're not going to train at a place that has 40 open choles, they've done 2 or 4, and those were actually part of a Whipple, right? Not actually part of acute cholecystitis. Then do you really want those residents and those junior attendings opening and doing an open cholecystectomy? Probably not. And so, but again, some of that's going to be based on your experience as a resident and kind of what you were taught. So this is complicated. It's hard, but I really enjoy this conversation because it shows that there's something that we can all learn.
Yeah, no, I absolutely agree with that sentiment, Mike. Dr. Virgilio, any final thoughts or questions before we sign off?
So I guess I'd just like to hear what's the final word then from the experts here. You're encountering a difficult chole and you're deciding between conversion to open versus fenestrating versus reconstituting near total cholecystectomy. What do you do? I want to ask each of the panelists.
I think you do what you're comfortable with. I think that that's the final answer. And I think that as we continue to work on our trainees, I really have continued to harp on the trainees about getting comfortable. And, if we need to learn how to deal with difficult situations. And, at our institution currently, we're going to continue to teach open cholecystectomy. And also, I think some of the subtotal techniques, just so that when they go out into practice, they have a lot of different things in their toolkit. But I also do really think that hopefully, we're training a group of general surgeons to continue to be comfortable working in the liver, and that it's not going to just defer to those few people that have happened to do hepatobiliary training, because the vast majority of surgeons in this country aren't going to be able to just defer to their hepato colleagues. That's a really special thing that you get to do if you work at an academic center. So I hope that we can continue to try to include open gallbladders in our educational curriculum for residency. But I guess we also have to, continue to train in bailout techniques as well. So,
Dr. Keeley, final thoughts.
Yeah, I mean, I agree with Dr. Neville. You should certainly do what you're comfortable with and what you feel is safe. Currently, for most gallbladders, I would still open, even being on the earlier side of being an attending. I'm comfortable. I like being able to feel with my hands the edge of the gallbladder and follow it down. And Dr. Kim and Neville and Virgilio taught me quite well how to do that. But having been around to parts of California, outside of here, subtotal is certainly gaining in acceptance and use. I do worry about changes in training, especially as a recent graduate, and just watching that change over the last 3 to 5 years, and the push towards single port robotic choles, 4-port robotic choles, and the lack of open experience and even laparoscopic experience is changing.
Thank you. Dr. Dissanaike, final thoughts and comments.
Yeah, so I think that one important point, so I absolutely agree, you should do what you feel comfortable with, but you should also be willing to look at your own data. So I think that goes to all of it, right? What's your recurrence rate? How many of your patients are going to other institutions to get their reoperation? We need to do that. And I think that's whether you're doing it open or subtotal, you need to follow your data. That's what we've tried to do. And definitely our data at our institution shows far better outcomes in the fenestrated lap Coley group. And so that's what we're going to do, or at least what I'm going to do for sure. But I think we have to follow data and go that way, because that's the only way we're, as a community, going to get to the right answer. But I also think as far as training residents, we need to give them tools in their toolbox. They can't all be mini-me's and just like us. They've got to have a range of options. And I think they will pick. There'll be some residents who'll be more comfortable converting to open, and there'll be some residents who'll be more comfortable doing a lap subtotal. But if we don't give them the options, and I think we've done them a disservice, especially as Mike said earlier, we're evolving. We are going to evolve whether we want to or not. I think we need to prepare them as best we can.
And last but not least, Dr. Truitt.
Yeah, no, great conversation. Everybody's made great points. I think we just have to keep pushing with defining terms, defining techniques. So often we get lost in heterogeneous data that was not really clearly defined. Again, a technique wasn't defined. The nomenclature wasn't defined. And then I don't think we ever get to the right answer. So I don't know the answer to this question. I think what everyone has said, that you should be doing whatever you feel comfortable with, what your skill set is, what your institutional resources are. And you can never go wrong with individualizing that patient's care to your experience. But I think we all have an obligation, and that's something we would all agree on, to continue to define these terms and try to get to an answer as to what is the quote unquote best and under which circumstances. So I appreciate this conversation because it's helped me get closer to that.
Well, that wraps it up for another episode of Trauma ICU Rounds. I want to thank you so much for joining us, and I hope you got something out of this episode. I know I did. With this particular panel, it was great to hear other people's perspectives and experience with subtotal cholecystectomy, which again is not a procedure that I'm very used to. And it just so happens that open cholecystectomy is my favorite emergency general surgery operation. I think that open chole still do have a role in residency education, and I do think it is an important skill set to have in your armamentarium. If you like what you're hearing, please let us know and share it with the world. You can visit us at iTunes, Spotify, or wherever you would normally download your podcast. We're on all the major podcast directories. Leave us a kind comment and rating, and make sure to let your friends and colleagues know about the show. If you have an idea or you want to hear from a particular trauma surgeon, intensivist, or researcher, drop us a line. You can reach us at traumaicurounds@gmail.com. Check out the show notes for this episode at traumaicurounds.com. Until next time, please stay safe, keep reading, take care of yourselves and one another.